Good evening, everyone. This is Dr. Marcos, and yes, I'm here from my desk today, and I have a very special guest on this webinar series, Optimizing Primary Care. We have a very interesting conversation ahead of us today, but I always like to start with the quote of the day, just to get us in the mood of what we're going to be working today and talking about. It's many interesting conversations today. And here we go with the quote of the day. The good physician treats the disease. The great physician treats the patient who has the disease. Sir William Osler said that some time ago. And in the same way that we collect all this information from patients and we have all these magnificent tools these days, we cannot never forget that we need to treat the human. We need to treat it holistically, and mental health is not the exception. Okay. Before we take off, I want to encourage you to take a quick look at a study that we're running. It's a survey study. Um, this survey study is to access your understanding or whether or not digital medical tools are of usefulness for you in your practices. So there's a link in the right here in the chat. Click on it, and then it will take you directly to that. So without further ado, let me introduce our first panelist and co-host. I give you the one and only Mr. Troy Grogan, our president and CEO, QHSLab. Good evening, Mr. Grogan.
Good evening, Dr. Marcos. Thanks for the introduction. Welcome, everyone, from QHS, all our favorite accounts and customers. By popular demand, the Optimizing Primary Care series continues on. And we're really looking forward to this conversation because we have a lot of feedback in the field about this particular topic. So I'm going to enjoy having a session with Dr. Goldbrand. So over to you, Marcos, to introduce the good doctor.
One of the things that I really enjoy, it's one of my mentees. They go the long distance and they realize their careers and they are doing better than me. I love that. And I have today one example of those. Bragging rights a part of that. The important thing is the speaker we have today. Our speaker started his medical career in Egypt. He is from Egypt. And then he came to the United States, started training in research. Specifically, he did a postdoctoral fellowship in behavioral cardiovascular medicine, that connection between the brain and the body. He was under we at Larkin Community Hospital training for those 2 years. And then he went up into a residency program in adult psychiatry, and he was not content with that. He has to go more. And then he completed 2 additional years in an accelerated pathway adult psychiatry. He converted himself into a child adolescent psychiatrist. And today he's an assistant professor, clinical assistant professor at Rush Medical Center. He's also a associate program director of the fellowship in child adolescent. Plus, I can keep going. He is also a directing and the coordination of the consult liaison programs in Rush Medical Center. Without further ado, here we have Dr. Bishoy Gubran. How are you?
Hello, how are you? Thank you so much, Dr. Sanchez, for the introduction. And I'm really excited to be here today with you and with Troy as well. Appreciate it.
I'm so looking forward to this conversation because we want our friends of primary care to understand how mental health could be addressed at that level before passing over to a specialist like yourself. But let me set the tone. Let me point out something here because I want to give us a perspective on for the last, especially post-COVID, post-pandemic. There's been a lot of in the news. Hey, mental health is an issue. Mental health, mental health, mental health. How bad it is? Take a look at these numbers, some of these numbers. 30% of your patients, meaning 10 are going through that door, at least 3, they have depression and anxiety. Undiagnosed cases, half of the patients are undiagnosed for these important issues. Suicidal risk, many of these patients, they saw you, primary care practitioner, at least in the last year. You know, it's like around 45,000 people committing suicide every year. That's the size of a small town. That's incredible. Then sleep, insomnia, increasing the risk several times for these depression and anxiety. We see that every day, more and more patients have that stigma. I don't want to have that. I'm crazy person. And we need to start to understand how to deal with those. How physical health can affect mental health, and mental health can affect physical health. So trust me, it doesn't matter what you do with your hypertensive. If the mental health issue is not addressed, there's not going to be hypertensive control. Which brings me to the point of today's conversation. What is a behavioral health integration program? How we can collaborate with the specialist at the other end, but taking into account that is my patient at primary care, and what are the tools that you as a primary care practitioner have under your disposal to make that happen and offer these services to your patients. So Dr. Gubran, let's kick this start. I want to know a little bit of what you do, because you are director of these consults. I can imagine you have many patients coming from primary care. What is a typical day in your consult?
Yeah. So I work in consults both in the hospital, and I did work in the collaborative care model. And maybe I think I can zoom into the collaborative care model a little bit, because that would be pertinent to our discussion today. So the way I would describe collaborative care model, for me, it's like a framework or a structured approach to integrating behavioral health in the primary care settings. So typically, it would have a team-based approach to that patient, and typically it would have 3 members of that team. On the very top is our PCPs. They are the coordinating the case. They are managing the medical issues, managing also the behavioral health component of it, and the main medication management, and almost coordinating the hierarchy of the team coordination. There's also a care coordinator. Sometimes that care coordinator is there, either a licensed social worker or a behavioral specialist, like a psychologist, sometimes a nurse, that's kind of coordinating things from behind the scene, and then the consulting psychiatrist. So these are the 3 parts, and sometimes it's just 2 parts of the collaborative care model. And the psychiatrist is providing consultation on diagnostic clarity, medication management, monitoring, and sometimes taking part of the care and then passing on the care back to the primary care physician, who is, or sometimes just the consultation on where are we, what are we doing now, maybe the titration schedule, etc.
Okay. So in the context of a behavioral health coordination, behavioral health integration, something very important to mention that it's the PCP level, all the regulations establish that there should be a coordinator, but doesn't have to be necessarily a behavioral health specialist. The reason behind that is particularly the fact that we have not many behavioral health specialists in America. And that kind of limitation, it was one of the key drivers to put together this framework of the behavioral health integration. But I know that probably every day we identify as a PCP many of these patients. Mr. Grogan, do you have I know we were talking this morning about particular patients that may benefit from these models, but how we identify them at the primary care level using our typical tools that we have?
Yeah. So the typical case that we experience in that collaborative care model where we get consulted on, there are many like general categories that I may speak about first. One of them is diagnostic clarification. We know that in the DSM, our diagnosis Bible in psychiatry, there's a lot of symptom overlap. And more often than not, there is also another psychiatric comorbidities that's either confounding the picture or leading that diagnostic clarity to be not there. So in those cases where there's either diagnostic overlap or comorbidities, whether psychiatric or medical, that's confounding the picture and making it very sometimes more challenging to get to know what am I targeting in order to treat it in an efficient way. That becomes something that we can come in a behavioral health integration model and assist in that diagnostic clarity. What comes to mind when it comes to psychiatric comorbidities are things like, let's say, depression. Let's talk about the bread and butter. Depression, but then in the background, there's also OCD. So which one am I targeting? Which one am I, because OCD would lead us to titrate the SSRI to a certain level. Depression needs a different approach. So that's one example. Another is like substance use. How are we going to target that substance use? Is the substance use the cause? Is it this substance-induced depression? Or it's actually organic primary psychiatric illness and it's masquerading patient is self-medicating with depression. So in that sense, there is that confounding factor. Another one is, and I'm just using depression as an example, and we can go into specifics, is personality disorders. If, for example, a patient with MDD and personality disorder, whether it's cluster A, cluster B, something like borderline, etc., it creates a false sense of treatment resistance for the depression. And then that would confound the picture. So one of the main things that we see is that quest for diagnostic clarity when there is lack of it because of either so many comorbidities, whether from the medical world or psychiatric world, and or comorbid cases that makes it challenging to know what I'm really targeting in order to treat it accordingly. So that's one of the things we see.
So if we have these conditions that I'm showing at the screen right now, there are typical psychiatric manifestations or disorders. But again, comes how, and this is for Mr. Rogan, Troy, there's a way that we can go into this funnel in process because you have the universe of all these patients coming to primary care. But then I need to kind of narrow that down, such as thinking needle in the haystack kind of approach, population, health population, that we have all these patients. What are the ones that really need to get into BHI and potentially seeing Dr. Bishoy?
Yeah, well, I mean, as you say, population health management, it all starts with assessing the population in primary care, and everyone on this call is a part of the QHSLab population health management behavioral health screening process. So it's universal screening, and it's well recognized by the Preventative Health Services Task Force, anxiety screening, depression screening based on all adults. Using instruments such as our PHQ GAD-16 to identify patients that are at risk. And then it kind of goes to the question for the specialist. It's never clear cut, but which patients are, to be managing primary care and which patients are appropriate for referral to a specialist. And like you mentioned, Dr. Gubran, it's that PCP as the quarterback, maintaining the relationship. And that's the great thing about the new CPT codes that were brought out in 2024, that we've been working on over the last 3 months to launch in 2025, this behavioral health and psychiatric collaboration, and making sure there's measurement-based care, not just, we've got evidence-based care and guideline-based care, but measurement-based care that goes along with the BHI program. So yeah, it's, as I say, it's never clear cut, but when to refer, when to treat, what are these, what recommendations would you give, Dr. Gubran?
Yeah, to firstly comment on the measurement-based care, I really like that. premise because we always want to objectify and concretize the symptoms. And the way to make it objective and have it numerical so that we are tracking progress and tracking improvement is by using scales. So scales are always our friend in managing progress after starting medication or assessing the severity as a screener in the very beginning. So I just wanted to piggyback on that part, which is the use of screening. So the one thing is that, like we mentioned, the diagnostic uncertainty is something that I would definitely encourage the consultation in that angle. But also if there is a form of treatment resistance, let's say that a patient that comes with depression, you started an SSRI, titrated it to an appropriate therapeutic level, and then there is treatment resistance to that medication. Let's say that you switch to another SSRI and still you're facing that treatment resistance, then that would be a good point to consult or use the behavioral health integration model in order to see what is the underlying cause of that treatment resistance, or should I use an adjunct medication that helps with the antidepressant, or should we use a multimodal where we are referring to a behavioral therapist, consider something like ACT or otherwise. Like I'm just saying that in that angle, when there is that treatment resistance, it's a very good case to have that consultation, because through that teamwork, you will be able to maneuver through that resistance into creating a care plan that is most tailored to the patient.
So talking about care plans, there's a statistic out there that suggests that people 65 years age or more in America are taking 3 or more medications. That adds some complexity to care plan and medication management. So we talked before about diagnostic clarity. Yeah, a well-done diagnosis is it's the pivotal moment that I then decide this care plan. But also in this BHI care coordination, how the PCP could benefit from the behavioral health specialist consult for specifically for that medication management, the appropriateness of the treatment in the context of this patient doesn't, it's very unlikely it's going to have one medication. It's very likely it's going to have 3 or more medications. Can you give us an insight on that regard?
Yeah, so we're talking about the polypharmacy, right? Like a lot of medications prescribed the same. Some of them are producing side effects, and for that side effects, you're giving medication to target that side effect, which is a cyclical pattern we see with many patients with medical issues and comorbid psychiatric issues. So prescription hygiene, in that sense, would be a great consult for the behavioral health specialist in the team, because it not only, and I want to also put this into 2 categories. One is prescription hygiene, but also if there is a medication that it needs a lot of monitoring, like for example, lithium needs monitoring of the lithium levels, needs the adjustment and titration of it, needs that kind of like expert support in that angle, that would be a good case. Or let's say somebody starting clozapine, which needs specific type of monitoring for many of the side effects, including weekly blood levels in the beginning for CBC, etc. So when it comes to challenging medications like that needs someone who is very into the titration schedule, what to look for, what not to look for. And to your point, the prescription hygiene, I think these are definitely great cases to have that BHI model assistance in.
And we wait, we have to make a difference here, because you talk about lithium and already we're getting into more serious mental illness arena. That's definitely your field. I'll send you let's say the bipolar patient or the schizophrenic patient, because that is serious mental illness. But for some of the more common, more likely encountered in primary care. So Survey speaks here to summarize when I should seek help from these behavioral health specialists, diagnostic clarity, polypharmacy, making sure we line that. How about the care plan, the appropriateness of the care plan? Let's talk about timing because some models say no, the patient should be in a behavioral health integration for 2 weeks, or 1 month, for 3 months. How do you know they should be for 3 months, 6 months? What you take into consideration to prescribe a given time period to see changes in those patients?
Yeah. To be totally frank with you, it's very difficult to extrapolate just from the very initial symptomatology how the pathway of it will go. Anecdotally, I've seen both ways. Like a patient that I would say, oh, maybe this is just a one-time consult and then things will go good. And then there is like possible family history of bipolar and they respond in a very paradoxical way to the medication and they need like the period is extended. And in contrast, you see, so it's difficult to tell. However, a good gauge is that it depends on the complexity of the case. So more often than not, we will just like sometimes consulted for what is the tapering schedule for this medication, help us with the tapering off of that medication, or management of one of the side effects of the medication, or the titration schedule, how does that look like for this medication that this patient is on to reach an optimal level. So in that sense, there are those angles, but then there is the other angle of patients who are with evolving complexity, like the diagnostic complexity, and then the paradoxical responses to medications. And in that angle, they might need to be more lingering consult in that case.
There's a proxy here that we say we seek progress, not necessarily perfection. But you mentioned something before about let's screen in an objective way, having score, and then track that patient in time. And probably this is going to give us an indicator. So I believe, Troy, that there's some tools and report tools that instead of me going to the EHR in and out and opening gazillion kind of different windows, in a simplified way, I can see if my patient is trending towards recovery, or I can see if my patient, you know what, had a setback. If there's some tools that we can use around those lines.
Yeah, can you share my screen? I'm showing this is sample data, but it's real but sample just for HIPAA reasons and all of those good things. But this is our PHQ GAD16, which everyone's very familiar with, I'm sure. Dr. Goldberg, you're looking at a snapshot. It's a cross-sectional. This is a real patient, but a snapshot. What's fascinating for us, because the three of us are co-authors in a paper that's just been finished after a good deal of work. Marcos, just for the fact that it's right there, what's the Q-neg with the Q scale? Just explain that for us, and then we'll get into the measurement here.
As one of the instruments is a psychosocial scale that is used as a measurement of overall well-being, but at the same time has some predictive power in terms of whether or not that person is going to utilize more healthcare throughout a year. And whether that's mental health care or physical health care, we've seen that patients that score high in this particular instrument, it's more likely they're going to be seeing more the doctor, or complaining more about pain, or being less satisfied with their care because they are going to be seeking more of that help. That basically is the summary of that particular metric.
A good warning sign. Yeah. And so, Dr. Gilbrand, you've seen this for the first time, and as I say, it's cross-sectional, but we've got our, PHQ-9s and GAD-7s, and we also have a chronic pain assessment, the physical side of, mental health effect, and a physical functioning score, which is out of the SF-36, is function actually affected as well as mental health. Even with our help from our medical director or medical advisor, the psychiatrist, Dr. Ohms from Miami, we've even addressed some potential ICD-10 codes that go along with the patient's responses. But again, as a psychiatrist, Dr. Gubran, what's your initial impression of these scores?
I think they capture many of the bread and butter presentations that we get. So it's like a wide net that captures and assess for that. I like that it includes a lot of somatic symptoms as well and physical symptoms, including pain and physical functioning score, because certainly that affects a lot, chicken or the egg, the psychiatric condition. So it's at least exacerbating it or causing it in some cases. Notoriously, chronic pain would do that. So I really like that it's included in that. More so, I like that there is a method to track. And the method to track is very important, and it helps us a lot. Like some studies talk about PHQ-9 improvement to 20% in 2 weeks, shows you that there is significant improvement in the and it helps us because 2 weeks period versus the notorious 4-6 weeks that we know about SSRI. But 2 weeks, 20% improvement in PHQ-9 can tell us that there is a positive response to this SSRI, and so etc. And it helps also to have a way that we can objectively talk about the patient about their symptoms. Hey, this is your score initially. Now that we've done these interventions, now that's your score. It objectifies it to the patient and allows them to feel a sense of also that it's not subjectivities. So I really like that it's including as many as not only psychiatric scales, but also somatic and physical parts that are contributing directly or indirectly to the picture.
And I'm just
That's an
showing.
excellent point.
Yeah, Marcos, you can see this new report I'm showing for everyone. This, like Dr. Gulbrand mentions, this comparison report where we're now looking at a baseline versus a current status and the time in between, and is there a change? Is it going backwards? Is it going, in the right direction? And this is just an example of the PHQ and the GAD. So providers will be able to use this tool as a part of the BHI program to exactly see that change. And the alert system too, which you may well be familiar with, is helping from a population health management perspective to identify patients that may be at imminent risk, where they've answered that they have had some suicidal or self-harm thoughts. And so this system that is available to everybody allows someone in the practice to be able to identify patients completing assessments that are in the imminent risk category, or that are help seeking, their readiness for change status. They're seeking help in mental health areas or in sleep or in pain, which is a good indicator of a patient that's ready, willing, and possibly able to take some action. So this dashboard is live, and it's going to help a lot of practices to be able to triage patients into certain statuses for them. Risk factors identified. This is maybe they're not seeking help, but we're identifying risk. They may have, as we mentioned, self-harm or suicide risk, or they need sleep, or they have persistent pain and poor functioning. So this dashboard helps at a population level to help identify patients. And then as I shared, the BHI program then helps to track and follow up and provide that measurement on a regular basis. And just while I think about it, just talking about, the normal kind of, I hate to say it, but the normal patient that has, the moderate type of depression or anxiety, we talk about medications all the time, but what are some of the non-pharmacological evidence-based treatments that the primary care physician can be implementing that have good, as I say, good effects, good evidence? Really interested in that, Dr. Gubran.
Yeah, I mean, it depends on the severity, definitely. If it's a depression to in the form of a very mild depression and one that does not, cross the threshold where they need the medication. I think the recommendations that are follow a good exercise routine, which recent studies have shown that to be very effective. Healthy diet, monitoring the TSH, looking at the vitamin levels, make sure that the vitamin D, there is no deficiency, vitamin B12, doing a CBC because anemia can more often than not masquerade as depression. So looking into all of the labs, doing a thorough medical part, and connecting them to therapy more often than not would be something that would be a really good start to CBT, cognitive reframing, cognitive restructuring would be a great way to, start the case. And then at least now they are connected with somebody who is consistently monitoring them and assessing for risk factors, etc.
I have a perspective that this perspective comes from the regulatory research world, but basically it's clinically, it's the essence of the clinical treatment. So we ask ourselves, we want to know how well my treatment or how much is helping my patient in these three ways. Number one question I ask, are my patients living longer? Are my patients living longer? We can access that. We can measure that. Okay. Two, are my patients saying that they feel better? So that's a more subjective experience, as you were mentioning, Dr. Bishoy. And then here's come the third one. Are my patients functioning better? So when you capture that somatic, physical, when you capture that mental, that way of thinking, but at the same time, you marry that with health journeys, with a series of resources to help you, the provider. So you have the pharmacotherapy, and then you have these health journeys with other resources, digital therapeutics, exercise, eating better, getting sunlight. Then you have that extra aid. So we talk about, okay, we're consulting here BHI for diagnostic clarity, going back again to the polypharmacy, how adequate my treatment plan is. I'm tracking patients, but how about a holistic way to treat the patient that takes into account both physical and mental well-being? You as a psychiatrist, are you only looking at the mental symptoms, or you're also considering, as you mentioned before, pain and other somatic factors? Can you give us some insights into those somatic or physical health aspects that you, as a psychiatrist, you're interested to know more about those?
Yeah, so firstly, we always start with the physical attributes, and for that we need that conduit to understand what's really going within the system. Does this patient have inflammatory conditions, for example? Does we look into the blood work, we look into their habits, we look into their sleep quality, because sleep quality affects all other psychiatric conditions because of circadian rhythm disruption, sleep architecture disruption. We even ask about nightmares and the depth of sleep, etc. More often than not, in a case we can send to sleep for them to have a sleep study with sleep medicine if needed. So in that angle, we look at sleep as one of our integral things we look at, but also pain. Because pain not only worsens, it can be a culprit in worsening any symptom and even triggering and unmasking symptoms of psychiatric issues. So we look into that. We look into medical conditions that themselves can lead into psychiatric manifestations. So some medical conditions, because of their inherent, inflammatory increase of inflammatory cytokines, TNF, etc., can lead to depression themselves. So you want to track that and see if it's well controlled or not, because more often than not, there also is psychological factors that can affect their medication compliance, etc. So we are usually in that angle work hand in hand with the primary care provider or the medical provider in order to coordinate care so that the patient psychiatric condition is not affecting their medical condition and vice versa. So in that sense, we are in a team-based approach to the care in that angle.
So if we think about in a correct assessment tools, and if we put the two into silos, it's not a good approach compared to a more holistic, okay, health assessment that includes physical aspects. I like that example of the inflammatory condition. Allergic rhinitis is an inflammatory condition. Rheumatoid arthritis is an inflammatory condition. And it's been shown that those patients, they have a higher incidence of psychiatric manifestations than other patients. That's one. We also know if that mental condition is not taken or is not addressed in an adequate way, it's not going to make much help in their physical illness. And I was reading not long ago, and this is an interesting fact here, that patients that commit suicide and they do biopsies, okay, post-mortem biopsies of the brain, they find higher levels of inflammation in the brain. So, and we're thinking, no, this is just mental, it's just in your brain, but that physical mental connection is real. And the primary care practitioner, it's basically addressing all of those physical conditions, but we have to put it into the broader spectrum, broader kind of a way to integrate it into the day to day. So now,
And I think it's
uh,
oh, sorry to interrupt you. Go ahead.
no, just to close that, I was struck when you mentioned as a psychiatrist. No, I want to know about their functionality. I want to know about their pain, how those things are interfering with their psyche. Because now, if I'm an old person and then I need help to stand up from my chair, that affects my psychological well-being. But are we measuring those at the primary care level, or we have the tools to do that?
Yeah, I wanted to allude to one point you mentioned about the suicidality, to take that into consideration as one of the main reasons that we get consulted on in a behavioral integration, health integration model. Of course, you know, if a patient is an imminent risk to themselves or others, you will send them to the emergency department for sure. So if that there's that imminent risk. But if there is, for example, passive SI, and you feel safe about the patient, you know, etc., then that would be a good consult case. If there is like non-suicidal self-injury in the background and you feel that there is no imminent risk on the patient, that would be also one of the cases that you would have behavioral health integration assist in further elucidating, safety planning, understanding the underlying symptomatology, and establishing the level of care that the patient needs, whether that's partial hospitalization, intensive outpatient, or just outpatient care, which sometimes but also targeting and managing the underlying cause of that symptom.
Can we
Mark?
have in a report, Troy, that mental physical health interaction that it's clear cut to see?
Oh, you want to see the PHQ again? Was it Marcos?
Health assessment.
The same one I shared before, correct? Dr. Marcos?
Let's see. I'm waiting for the screen, but just the health assessment that has both mental aspects and physical health aspects, that includes other values as a sleep, as a allergy symptomatology. I think it's a good example of that merge between mental and physical health.
Okay, let's pull up one of those. We're live here, so let's see what I mean, this is a demo account, everyone, but we are live. So let's see what I can pull up. looking at health assessments, the combination of physical health, mental health, help-seeking behaviors.
Because this is more likely to be used by our PCP friends. Because again, I have stress. I have a moderate stress, but in this case is mild, but I may have other symptoms of bad sleep or poor allergy control or pain. And then if you put that in the context of patients that have a pre-existing chronic disease, very likely, then we're talking in a very different case that merits behavioral health integration. So what I'm going to do is, Troy, you can look for that in the background. Let me show here a
Well, here's
potential.
one.
Oh, here we go.
Here's one. It's a classic
Yes, yeah.
example of, you know, these comorbidities, if you like, or this connection, depression symptoms, you know, using the SNOT-22, the severity rating scale of the sinonasal outcome test, where we have a very, very severe condition. And then the domains within the SNOT-22, we can also look at sleep dysfunction, you mentioned, Dr. Gulbrand, and psychological and mood dysfunction as well, that is being, again, measured from their, you know, allergy and severity of allergies. So, you know, this is one of these patients that are, you know, if they're having bad sleep, if they've got a bad mood and they've got allergies, there's a self-perpetuating thing here, isn't there? The next day they're not going to perform well. They're not performing well, so it's adding to that. So we can't address one without addressing the other if we're trying to completely look after, you know, a patient. They have pain that's not yet persistent. Well, let's hope they don't get there, because you don't want them to be in the chronic pain stage. Another thing, this patient is not seeking help. All right, so let's talk about that one, Dr. Gulbrand. So look at these red, high depression risk from a, you know, cross-sectional perspective. Anxiety is not there yet. They're miserable with allergy symptoms, but they're not seeking help. When they're asked the question, would you like help? What do we do with this patient?
First, I would be curious, why are they not seeking help? And I think there is lots of symptoms, psychiatric symptoms, that are inherently causing that lack of motivation and avolition, like we call it. Like they don't feel hopelessness, helplessness, which are all typical symptoms of depression. So low help-seeking behavior itself could be a conglomerate of multiple symptoms that we see with depression: avolition, low motivation, low energy, feeling hopeless, feeling helpless. So they don't have a theory where things are going to be better. So they feel the futility of it. So that renders them in a way with poor help-seeking behavior. Another thing could be that they sought help before and they didn't get the appropriate help, where they feel a meaningful change in their symptoms. Maybe some symptoms were underlooked or you know, brushed upon as something that will improve with certain treatment, and were not. So they did not feel a meaningful difference, and therefore their hope theory about seeking help has changed. So I think the first part is that this is an important indicator to have high curiosity about why there's low help-seeking behavior, and then how can we empower the patient to partake and be part of their own treatment pathway and their own healing pathway, and they are feeling that they are doing this to themselves. And I think one of the main things is to give them good hope about our treatment. They feel understood and seen. And part of feeling understood and seen is that we are addressing symptoms across multiple scales and not diminishing the importance of one on the expense of another. And acknowledging that they have pain, acknowledging that their sleep is disrupted right now, and creating a plan that puts into consideration those multi-layered approach and not just focusing on one area.
So I want to put this into perspective. And what we're gonna do, let me switch gears here. Let me show you a case, what I would like to call the typical Mr. X Smith case. What you might probably see in primary care, and probably you've seen one of these patients. So I'll show you my screen, the case, okay? And then we can go through the motions here very quick. 67-year-old male, okay? CVD, hypertension, hyperlipidemia, very high, likely we have that kind of patient, multiple medications. Diagnosis initially based on the screening tools that are used, including the PHQ-9 for depression and GAD for anxiety. And then there's a clear score there, the cutoff point, 10 over, that it's clinically meaningful, meaning that they most likely have the clinical depression or anxiety. And then this patient is kind of the typical patient we enroll into a BHI. So let me ask you, that's we have this Mr. X myth. This is a patient that really needs very focused referral and have the behavioral health specialist taking care of this patient, or this is the typical patient that a primary care practitioner could basically take that patient into that behavioral health journey?
I think here, because of the complexity of the comorbidities, where there is hypertension, CVD, hyperlipidemia, probably he's on many medications for those as well. And those medications might have interactions on some level or another with our psychiatric medications. Many of our medications are inhibitors or inducers of the cytochrome system, for example, and the enzymatic system, and could affect levels of beta blockers at sometimes, levels of other medications for the heart thing. And in that sense, I feel in that patient would have the comorbid complexity, but also will have the polypharmacy we talked about before, and therefore the BHI can help guide with the titration regimen. And I mean, he's doing well with the sertraline, like you wrote in this case, for example. We reached a good level. He's doing well, no side effects, etc. Then the PCP can, take back the care in that sense after that consultation and bridge it to continue with the management thereafter.
So again, I'm trying to repeat these concepts too, because we've been enumerating reasons or good idea to have this early consultation inside the BHI for a patient coming from primary care. So there's a specific cases, as you mentioned. This, I put you very quick in the spot. This is the polypharmacy patient, as you mentioned. Diagnostic clarity, appropriateness of the care plan, and then we talk about the timing that is very hard to decide if, but initially we can say, okay, let's give it 3 months, and then we track. As long as we're tracking continuously, we can decide into that. And then there's another thing that I like to share with you. And I want to go with you and with Troy into these potential steps. So from a primary care perspective, okay, into different steps of this patient that is in my office, that 3 out of 10 might potentially be in the need of a behavioral health integration. And then we have the patient earliest screening, both mental and ideally physical health, and those comprehensive assessments. But let's dig a little bit deeper in that number 3, because this is the part that sometimes we get a little bit more specialized training. From a primary care perspective, once I have PHQ-9 over 10s and GADs, and we have all these risks, how I narrow down to come to that diagnosis? If we're talking that diagnostic evaluation, can you explain us briefly what is the process once you have all the pieces of evidence with the screening tools and so on?
Yeah, we use screening more often than not as a guide into narrowing down and directing us into how we will tailor the psychiatric interview, for instance. Now, the part of the diagnostic evaluation is sometimes if it lacks that specifier complexity, and I'll give an example of, let's say, case of depression. Patient have thoughts of not wanting to exist, hopelessness, helplessness, low energy, low interest in doing things, which we call anhedonia, fatigue, feeling of worthlessness, hopelessness, helplessness, and anergia and motivation, and no psychotic features, does not hear voices, does not see things, and that's just a depression. And that we have the level of it by PHQ-9. The second thing would be, okay, does he have any manic symptoms in the past? No manic symptoms, not bipolar. Okay, then that's narrowed down into the typical depression. And the SSRI would be a good option to start, for example. Now, let's say that this patient starts to say, well, yes, at night and in the middle of the day, I'm hearing voices telling me you are not worth it. And these voices are talking to themselves at some time. Now, with the added level of psychotic features, is this MDD with psychotic features, or is this like a schizoaffective disorder, or is this something that's a part of a bipolar activation that we're not really capturing it at the same time? So once there are some added layers of complexity in the presentation, that's when I feel the diagnostic clarity is part of what's needed in order to create that clarity about what we're targeting. And once we know what we're targeting, we just started, and then the titration can happen. Are we starting by antipsychotics, or are we starting by mood stabilizer, or starting by antidepressants, for example?
And for the most part, that kind of patient, it's around 1% of the total population. So it could happen. It could happen, but it's very unlikely.
Yeah.
Very unlikely. So you have to see 100 patients in a week, and probably one may
the bread and butter cases are, the major depressive disorder. Sometimes this is, MDD that would be very well responding to SSRI and some, therapy. So that's usually typically the bread and butter cases that you would face in, or someone with, history of bipolar, but they're doing well on the mood stabilizer already. And etc. So I think the bread and butter cases, or the majority of the cases, do not have the complex layers of symptoms that make it, very challenging.
I want to go back to an earlier point about help-seeking behaviors. At what point, I think in the discussion diagnosis and proposal BHI, can you share with our PCP friends at primary care level some of the strategies or techniques that you use to understand better why the patient doesn't want that help? I know you mentioned them, but let's say, let's play this persona. I'm this patient right here, and I have high depressive symptoms, I have high anxiety, and I don't really want help. I just want to get over this. Doctor, I don't want help. So why I should get help from you to address my depressive symptoms?
Yeah. Firstly, I would come from a place of curiosity. I would start by asking why does he feel like he doesn't want help, and what does help really constitute to him? Because different patients feel more often than not that the medical expertise is putting them in an a priori created box and treating that box, not looking at the nuance of their case. And in that sense, if they feel that way, they wouldn't feel empowered, because they have the subjective interpretation that you are targeting something else that you have in a box, but that's not really addressing the main problem. The main problem may be a psychosocial problem. The main problem may be that he's going through exams, or that the recent. So in that angle, I just want to clarify first and understand the really digging deep into the symptomatology in order to reflect that back to the patient, so he understand that I really have a deep and nuanced understanding of his case, And my experience is that once I'm able to tell the patient that I can perspective take him, really able to tell him exactly the constellation of symptoms that are main priority for him, what is bothering him the most, and how am I going to target those and create a hope theory for him that is different, and show him that I'm going to be addressing the main elements. More often than not, patients will be like, I have so much pain, but you're telling me, yeah, you're going to start me on an antidepressant, but you're not really targeting this. So showing them that you are targeting this while also targeting this, for example, a medication that can target both, or something that you're addressing their concerns, and you're prioritizing the personalization of medicine in order to really target the things that they are worried about or that they're bothering them the most. Then in that sense, the therapeutic alliance starts to be way higher, and they feel empowered to be part of it. Definitely, sometimes it doesn't happen in the first time. Sometimes it happens in the second time, or with the aid of a therapist, or with after establishing some level of trust with them. And in that sense, it can be a journey.
And Marcos, if I could jump in here, because I just want to just go back to that health assessment that had the physical and the mental measures, where the patient actually said they weren't seeking help. And to your point, Dr. Gubran, the fact that that patient had severe allergies affecting their sleep and mood, and then there was a statement because the patient was asked the question just about OTC medication use, and they weren't using, what we would consider the first level nasal steroid, Flonase, fluticasone type of thing. They weren't using that. And I know you're not an immunologist or an allergist, but by just suggesting, okay, over the next 2 weeks, let's take, fluticasone, they may get those small wins that go on to be helping them overcome that initial, what's the doctor going to be able to do to help me anyway type thing. So
yeah, I think definitely showing interval improvement in a symptom that is affecting their daily life and affecting their quality of life would gain a trust. And building trust is the most therapeutic alliance, and rapport with the patient is the gateway to empower them into partaking into their journey. Because once they trust you, they know that their brain already registered that improvement that they had with your suggestion and your recommendation. Therefore, they feel empowered to seek help because they know that, oh, I have a data point where this worked. So now I just want to add on data points of how this may work in different areas and layers. And that's why, the continuity of care, with the family medicine or internal medicine, primary care, having that longitudinal relationship with the patients throughout many, and knowing them intimately, not only by scales, but knowing the psychosocial background, etc., and outsourcing when needed in order to make them feel like, oh, well, at this time, I'm going to send you to see a specialist. And then I'll still be your physician. I'll still care about everything, and they will communicate with me. And then you're back to me, and then we continue. So that continuous knowledge and disambiguation of the patient's internal and external life into understanding, so that we're really, like, sometimes for psychiatric cases, I would be trying to, if I'm able to close my eyes and visualize a day of this patient's life, then I understand them better. Like, oh, this is how they wake up. They wake up tired. They sleep, have problems falling asleep. They then have this like panic attack that's lasting 2 minutes in the day, and then they are not eating well because their appetite is low and they're not exercising. They're in the room. They're not showering. They're not brushing their teeth, and they're having arguments with their son and wife in the morning, and then sitting at home, not really enjoying music anymore, and not going outdoors. They look like, so it's just like able to visualize their whole day. And so I become very, very close to their symptoms and become very intimately understanding. Now, add to that, I have an objective way of monitoring their progress in certain things and showing them, like, well, you see here, you were doing your PHQ-9 was 10, now it's 16, or now it's much better in that angle. And that would tell them, oh, well, yeah, I'm doing better and I feel better, but also doing better. You have 10% improvement in this week only. And you know, that will also instill hope and instill trust that it's not only intersubjective agreements, like, yeah, you're doing better, I'm doing better, though it's just more concretized and objective.
Just
This is a great way to summarize. Go ahead, Troy.
just like in physical medicine, the family medicine doctors, internal medicine, every day are doing systems review, the physical symptoms. Well, you know, there's the medical symptoms review, or the mental health symptoms review as well, as you point out.
Yeah. So we're mentioning, you see, we're being full circle here because we started with the quote of the day. We don't treat symptoms, we treat the whole patient. And Dr. Bishoy, you just basically encapsulated that concept of, yes, here's the tool. I go through the report. I see what is bothering you. You have taken the time to answer these questions. And now I have pieces of information to make a clinical decision. And we're going to be together working towards the betterment of your health. And those tools are there. They're right there at the disposal of PCPs. I mean, again, it being a wonderful. There's so many things that this conversation can spin up, but I want to I want to take now time to open the floor for some questions that we may have. By the way, take a look at the chat very quick. Please, I will appreciate if you can help us with this survey. It's like around 10 questions, very quick. You can do it as we talk, and if there's any questions regarding BHI's strategies for the patient that may be identified as potential high risk for any of these mental illness. When I open here the floor, you can type in the right here in the chat if there are no many questions. I believe Dr. Bishoy is a busy doctor. He's about to round in a few minutes. But before he goes, I want to make sure that all the questions are addressed. If not,
I'm paraphrasing Dr. Marcos, one kind of question here. It's like workflow, really. I mean, there's the everyday workflow, you know, like what Dr. Bishoy, what challenges can you imagine that you've actually seen in integrating BHI, behavioral health integration in primary care settings? We've spoke about a lot, I guess we're summarizing. So what challenges could you imagine or have you actually seen in your collaborative care models? And how would you propose to address them? Like, if you can, in a couple of minutes.
Yeah. So one challenge that is definitely I've seen or experienced is that there's sometimes difficulty in getting patients to be seen as, you know, mental health concerns can be the priority of the patient. And now let's say they are on medication that's not working, they're not having a positive therapeutic effect for it, and they are referred for the BHI model, and that takes a long time given that there are many cases provided. So one of them is a time lapse between the symptoms, and that leads sometimes to, you know, symptoms worsening naturally if you leave a symptom exacerbated. In that sense, having that expedited ability to reach out or coordinate the case and risk stratification, but also triaging, which are the priority here, which is the one that you know, can wait a little bit versus this one really needs to be seen now, is something that the care coordinator can sometimes facilitate so much. So that's one of the challenges that I've seen. Yeah.
And look, we're not in a perfect world. We never are we? Where does telemedicine play with getting in to see someone like yourself? We're about to embark on just starting in a couple of weeks in 2025, with this integration with a new center, brick and mortar center in Miami. We got a lot of customers, accounts in Miami, primary care, and this is part of the reason for this optimizing care conversation we're having. Can telemedicine fill a role?
Oh, yeah.
Yeah.
Especially in psychiatry, telemedicine is one, it will be one of the very few specialties that will continue to have telemedicine, which is telepsychiatry. I know it started and I mean, exponentially increased during the pandemic, but we've been able to see that we're very consistent and good results with telepsychiatry. And sometimes even in a surprising way, interestingly better than having them come to the clinic, because you're entering their home. You're seeing, how their room is, like their day-to-day life. You're getting in more. It's almost like they're inviting you to their place. So in a way, I'm not saying this is better than face-to-face encounter. Everything has pros and cons, but definitely telepsychiatry can be a way to facilitate and expedite that. Also expedite by allowing more providers to accessing that patient population.
Excellent. This was an enlightening conversation, Dr. Bishoy. I think we have covered a lot of material today, and there's more to come. We're going to continue this series and conversation with experts such as yourself in the next coming months, and we also going to add more resources, educational resources for the primary care practitioner. They're going to be available online. So we're again, as a QHSLab, we're grounded in science and in education, and we're going to make those definitely available, such as this video if you want to go over the highlights, and then we're going to make also some pointers of what we have as a conversation today. That definitely there's some hints and tips there for the primary care practitioner when they are embarking in this journey of the behavioral health integration. So those are my final remarks. Troy, you have some final thoughts and comments for everyone here?
I just want to wish everyone a joyful, peaceful, and happy holidays and New Year. It's been a tremendous year for all of us here at QHSLab. We've got over 110,000 completed assessments. Marcos, you presented at the American College of Allergy, Asthma, and Immunology, this link between allergies and behavioral health. You pointed out, Dr. Bishoy, about this biological basis in inflammation. You've also got the American Psychiatric Association papers coming up next year. There's been a tremendous amount of work in our real world data, and it's now at the forefront. So yeah, I wish everyone a joyful and peaceful and healthy holidays and New Year.
And Dr. Bishoy, a final word for the PCP, that they're not alone, that they can do this. They can give a better service and better care to their patients if they look also into their mental dimensions of their care.
Yeah, certainly. And I think there is so much value in understanding that layer of the patient and addressing it in a way that is intimate by their long-term provider, which is a PCP, and also that there is a support when needed in the form of consultation, BHI model, and we consult medicine all the time, consulting we're a teamwork, and I think that's the beauty of medicine, that we are all collaborating in order to really get the best patient outcomes. And yeah, thank you so much for having me, and happy holidays, everyone.
It's been a pleasure having you. It's been a pleasure having everyone. I don't see questions, but if you don't have questions tonight, it's fine. You can find me anytime. Dr. M series, we're sending these emails. You can email me directly if you have doubts, questions about the services, the tools that are available for you and your patients. And stay tuned, because we're going to have more experts such as Dr. Bishoy down the road. So without further, happy holidays to everyone. Enjoy. And I hope to see everyone next year with more exciting news, products, and services.